Okay, so I think we have a number of participants, and we may start now. Others will be joining as we go. May I welcome you all to the webinar. My name is Edward Kataika from ECSA Health Community. Very glad to have you once again in the webinar, the first for this year and the first in a series, which we're organizing for the ECSA Health Economics Community of Practice through the support of the Transparency program. Just as we did late last year, the webinars are organized as part of the knowledge exchange and continuous learning for members of the ECSA Health Economics Community of Practice and all others interested in enhancing their understanding and capability of health economics. Our topic for today is productivity analysis of hospitals and facilities. As we will hear from our speakers, they will be addressing issues of measurement and assessment of efficiency of hospitals. Efficiency assessment and improvement is one topic that is increasingly catching the interest of policymakers in our region and beyond. Many of you will recall that the World Health Report of year 2010 addressed the issue of efficiency and went further to identify the 10 leading causes of inefficiency in health systems. These, of course, included inefficiency at the hospital level. In all health systems, huge amounts of resources are allocated and utilized at the hospital level. And as the World Health Report observed, inefficiencies abound at this level. As such, improving the productivity and efficiency of hospitals goes a long way in addressing some of the leading causes of inefficiency in health systems. So in this webinar today, we will hear from two esteemed speakers on this topic. And I'd like to introduce our two speakers. First, we have Dr. Julie Jemtai. Julie is a health economist based at Kemri Wellcome Trust Research Program in Kenya. Her research interests are in economic evaluation, efficiency measurement, which we'll be talking about today, statistical modeling, and data science in healthcare. She leads several economic evaluation studies, specifically in acutely ill children in Kenya and Uganda. Julie has a background in economics and mathematics and a PhD in health economics. Her PhD research focused on efficiency measurement in Kenyan hospitals using frontier analysis approaches. Our second speaker is Professor Albert Makochekanwa. And Professor Makochekanwa is Professor of Economics and Senior Lecturer at the Department of Economics, University of Zimbabwe. He has over 15 years experience in economics and social science issues and has worked across Africa, including Zimbabwe, where he's based, South Africa, Botswana, and Ethiopia, and has published several papers and contributed to several studies on economic issues in Southern Africa. So before I invite the first speaker, just a few technical housekeeping points. First, participants are invited to use the Q&A box to post their questions. So as the speakers are presenting and you have a question, you can just type it in using the Q&A box. Please don't use the chat box. Use the Q&A box so that we can see it. So during the discussion, I may read the question or actually invite the person who posed the question to actually ask the question. Alternatively, participants may use the raise hand feature, which can be found in the participants panel. So during the discussion, just use the raise hand feature so that we can see you and ask you to ask your question. So Steph, who is providing the technical assistance, will unmute you so that you can speak. And then also just to mention that this webinar is being recorded, just like the previous ones, because we intend to post the recording on our health economics hub, which is on the Global Health Network, so that other people who have not attended this webinar and others outside our community may also have an opportunity of listening to the presentations. So just take note that we are recording this webinar. So with that, let me now invite our first presenter, Dr. Julie Jemtai, who is going to give a presentation on technical efficiency in Kenyan hospitals. Julie, you have the floor. Will you please unmute your mic? We can't hear you.
Yes. Thank you very much for that introduction, Dr. Edward, for this opportunity. Let me share my screen so that you can see the slides. I will disconnect my video too because of internet issues. Okay. Is it reflecting? So I can start?
Yes, please. We have
Great.
it on the screen.
Thank you. Thank you very much. Thank you for this opportunity again to present some of the work that we did on efficiency in hospitals. And in today's presentation, I'll be focusing on the Kenyan context and the work that we did within the Kenyan hospitals. Oh, wait. Yes. So the initial discussions on hospital efficiency was actually very earlier on. And in this case, I mean, William Allen emphasized on the issues of hospital efficiency in his paper in 1906. And he emphasized that reducing waste was necessary for service expansion because the taxpayer was reluctant to pay more or even to continue paying the same as long as there was a perception of misuse of funds received. But what exactly is efficiency? So efficiency of a production process basically measures whether healthcare resources are being used to get the best value for money. In simple terms, it's basically doing more for less. The terms productivity and efficiency are often interchangeably used to describe the comparative performance of production units. The other definition provided by Palmer indicated that it's a relationship between a specific healthcare product, in this case output, and in some cases outcome, and the resources used to create this product, and in this case it will be inputs. The different types of efficiency, I'm focusing on technical efficiency today, and it basically means producing the same outputs with less of at least one input, or using the same inputs to produce more of at least one output. The focus of efficiency analysis in any organization is what we call decision-making unit, or DMU. And in healthcare specifically, this can either be overall health systems, it could be individual hospitals or facilities, it could also be individual physician practices. The demand for efficiency analysis generally has increased, and there's been increasing interest, mainly due to concerns on increasing costs of healthcare, but also increasing demands for public accountability. In terms of methodologies, there have been improved capabilities over time in terms of measuring performance, efficiency, and this has necessitated sort of an increased interest in estimating efficiency. Kenya specifically has made a commitment to achieve universal health coverage. And in 2013, Kenya transitioned into a devolved system of government, granting the 47 counties autonomy over budgets and decision-making processes. However, the country's health system is still heavily underfunded, with the public expenditure on health currently standing at about 2.3% of GDP, rather than the expected more than 5%. So in order to achieve UHC in Kenya, the country will require additional funding, which will only be justified if the current resources are used efficiently. So how do we measure efficiency? There are different methods, there are different approaches, but today I'll be focusing on what we call the frontier analysis methods. And one of them is what we call data envelopment analysis, or DEA, which is a non-parametric deterministic type of model. And it uses mathematical linear programming model to construct an efficient frontier by joining the fully efficient hospitals, and then the rest are compared to the best that's on the frontier. So it's relative, basically. The scores for efficiency usually range between 0 and 1, with 0 being DMUs that have very inefficient, and 1 being the most efficient, and indeed they would be on the frontier. The other method is a stochastic frontier analysis, or what we call in short form SFA. It's, on the other hand, it's a parametric stochastic in nature. And the major difference and advantage of SFA over DEA is that it accounts for statistical noise or measurement error when estimating efficiency. There are several challenges of measuring efficiency. I've just highlighted some of them here. The first one is the ideal output, which in this case will be outcomes, the final outcomes, either improved health status or quality of life, are usually difficult to measure. And in most efficiency studies, they use intermediate outputs in order to estimate efficiency. In terms of capital, so some of the inputs, such as capital, are difficult also to measure. And they're either difficult and also rarely measured. Most of the studies do use number of beds as a proxy for capital. And we do know that the flow of capital services are measured in terms of capital input and not necessarily capital stock, as we see in this case. And this leads to a lot of studies overestimating efficiency. Ownership as an effect, as a determinant of efficiency, has varying results in literature, but with prior perception that non-government hospitals do perform better than the government hospitals. However, there are some studies that have disputed this claim in their respective setting and showed that public hospitals do perform better. In terms of the methodologies, there are still major challenges. There are pros and cons of different efficiency estimation techniques and methods. And some of them, it needs keen considerations when choosing the method to estimate efficiency. Just a bit of background in terms of the literature within the African continent. There's some studies in healthcare that have estimated efficiency. But in Kenya specifically, I've just highlighted 3 main studies here. There's some new ones that have come up. But one looked at the district hospitals level 4 efficiency and public health centers, which are level 3. And these were all before devolution. These studies were actually earlier on, they were published in the early 90s, and there's been a huge gap between them in exploring efficiency in Kenyan hospitals. A more recent study looked at efficiency at faith-based hospitals only. In all these studies, they were all a year or 1 year cross-sectional studies, and they all applied data envelopment analysis as their analysis technique. So this led to the interest in understanding some of the key research questions and key gaps in literature. And one of the questions was to first look at the current efficiency levels of Kenyan hospitals, but also to look at the changes of these efficiency levels over time. We did include ownership, hospital ownership, and to look at the influences would have on efficiency in Kenyan hospitals. And the fourth one, which is a more methodological questions, is to look at the differences between the results or the scores that we're getting from the efficiency levels between the 2 frontier analysis methods that have been recommended in literature. So what's different in the study compared to the previous studies? As mentioned, we did apply both DEA and SFA methods in this study, but we also collected data primary data from the individual hospitals rather than collecting from secondary sources or a centralized system, which at that time when we did check or did an analysis, quick check, there was issues to do with data quality and accuracy. So we opted to do the primary data collections from the individual hospitals to assess efficiency. But in this study, we've also used a 5-year panel data to estimate efficiency, and I'll be presenting some of the results on that. And we've also included hospital ownership as a determinant of efficiency to try and understand this aspect as highlighted as a gap in literature. So we collected data before devolution. So this piece of work is before then. We analyzed data from 27 level 4 hospitals across different regions in the country. We initially was set out to collect from about 36 facilities. We had challenge in either accessing the facilities or getting full or complete data sets from this hospital, from those other hospitals. So we excluded them from the analysis. 20 of these hospitals were public or government hospitals, and then we also had 7 faith-based hospitals. We didn't include private hospitals due to accessibility to data from those hospitals. We collected data between data that was assessed or collected routinely between 2008 and 2012. And I'll take you through some of the results showing that I only picked 2 years for what you call cross-sectional data sets for the data envelopment analysis that had the most complete data in this case. In terms of the variables inputs, we collected data from different staff cadres from all the hospitals we included. We also had collected non-staff, specifically non-staff recurrent expenditure, and also number of beds as a proxy of capital. In terms of outputs, we focus on the hospital workload, number of outpatient and admission. It had the most complete data. We did have other outputs, but we didn't include them in this final analysis. For the purposes of comparisons with stochastic frontier analysis, which requires a single output, an index of workload was derived using the Fisher's method. In terms of determinants, I did include several, but in this presentation today, I'll focus on ownership. And as mentioned, I did apply DEA and SFA. In terms of data envelopment analysis, we further looked at the bootstrap data envelopment analysis, mainly because of several reasons. One, for the bootstrap DEA, it can be used in relatively small sample sizes, especially in this particular study. But secondly, the measures of efficiency we do know are very sensitive to sample variation and therefore allows correction of sample bias. But we can also get the opportunity to conduct statistical inference methods and can be applied on a bootstrap DEA. For the stochastic frontier analysis, there are 2 models. So we had the cross-sectional for purposes of comparison with DEA, but we also did an in-depth panel data model. And in terms of the specific models, the time invariant model have 2 major setbacks. They do assume that there's a constant inefficiency over time, which is unrealistic in long panel data sets. But they also include time invariant, hospital specific unobserved heterogeneity, which in most cases tends to overestimate inefficiency. So in order to attempt or sort of to relax these assumptions, we use the time varying models, and in most frequently in literature is actually a BEC model, random effects, which is the Battis and Coyle random effects. And that's what I'll be presenting in today's presentation. So just to take you through some of the results, when we start by the first question was to assess the efficiency levels of the Kenyan hospitals. When we did run the bootstrap data and development analysis for the 2 cross-sectional data sets, we did find as an average score of about 0.85 for both years. And basically this means that the hospitals need to improve their inputs in order to achieve the similar outputs by about 15%. And that sort of varies across the different facilities, but we do see as low, some of the facilities like facility 13 as low as around 0.4. When we did run the stochastic frontier analysis panel model, we do know that with SFA, the ordinary least squares, the OLS, estimates of a production function are first derived. And then this is used to obtain the maximum likelihood estimates. The parameter estimates are, you can see them here. All of them were not significant except for NASes, which was highly significant, but it also had the highest magnitude, as you can see here, compared to the other inputs. There could be several reasons for this. This could be an indication that NASes are key drivers of hospital efficiency and play a major role in hospital activity processes. But the other reason could also be that NASes are not easily substituted compared to the other cadres and can perform various tasks within a facility. However, we have to be cautious. The results might be different if the efficiency is analyzed by case mix, or if it's analyzed within specialized care units, where some of the cadres like doctors might come up strongly when you run this efficiency model. The beds is the only one that had a negative coefficient. This is actually consistent with a lot of literature, but it might be an indication that it's not a binding factor in the overall efficiency of hospitals, but definitely there's need to explore this further and do some further analysis with larger data sets. Gamma here, of course, presents the percentage of total variation due to inefficiency. As mentioned, SFA accounts for noise and measurement error. So it splits into two, the inefficiency score and measurement error. What this means here is that this model indicates that 94% of the total variation is due to inefficiency, which is good. There's minimum noise around it. The mean efficiency level was much, much lower when looking at the panel model at 0.62 for all the 27 facilities, indicating that the facilities potentially needs to improve their inputs by about 38%. Great. When we looked at efficiency levels over time, we didn't see much of sort of a particular pattern, and it wasn't significant when I assessed this over time. So it was a bit of oscillation, but there wasn't any significant direction of efficiency levels over the 5-year period in the panel data. I apologize. Hi. Hello?
Yes, we can hear you.
Sorry about that. We just lost Wi-Fi here, but I've connected with my phone. Can you still see the slides, or should I reshare?
Steph, would you like to assist with that?
Can you see the slides? I can reshare again because I just lost the internet.
Hi, Julie. No, we can't see the slides. If you're able to reshare, that would be great. Let me know.
Perfect. Let me know when.
Yes, we can see them now.
Fantastic. Now, I'm not sure where I lost everyone. I'm hoping it's around ownership.
Maybe if you can just go one slide back.
Okay. So in terms of efficiency over time, so we didn't see much of a significant direction or pattern of efficiency over the 5-year panel data. And this can also be seen by the individual hospitals, with all oscillating up and down over the time with no particular direction. So there wasn't any particular direction. It wasn't significant at all over time. In terms of ownership, when we did the analysis using the data development analysis, I'll present later on the ECSA, we didn't see any significant differences between the two facilities, public and faith-based hospitals. There wasn't anything between, for both the years, 2011 and 2012. When we did run this two-stage model, the Seaman-Wilson two-stage model, where you regress the efficiency scores with the determinants, for example, in this case, ownership, we also didn't find any statistical, we didn't find ownership as a statistical factor in efficiency or inefficiency in the Kenyan hospitals. And my last question on the methodological aspects and to see whether there were any differences in terms of efficiency between the two methodologies. When we did check the correlation between the two methods in terms of the efficiency scores, but also in terms of the ranking of the facilities, for the 2011 data set, there was no significant correlation. There was a significant correlation in the 2012 data set, which had the most complete data in this case. But we can still see that the correlation coefficient was still very low generally between the two methods, indicating that there might be differences in the two approaches. Very slight differences. This particular graph here is what we call a bin plot with a solid black line cutting across each of the bin plots, indicating the mean value. And the white small lines inside the bin plots are the individual efficiency scores for the individual hospitals. What I'm presenting here in this particular graph is actually the traditional data and development analysis. This has not been bootstrapped. So it has not sort of corrected for any sample variation or sample bias. And we can see significant differences between the two methods, with SFA having much lower scores. This is interesting because in literature, there's a lot that has shown the vice versa. But one thing we just need to highlight here is that the major disadvantage with data and development analysis is that it's very sensitive to data and tends to specify many DMUs or many hospitals on the frontier, or basically having the score of 1. And you can see it's here in this case where a lot of hospitals are all clamped up at the score of 1. This might be an indication that these results of the data and development analysis are driven by the relatively small sample size. But when we now corrected for that and ran the bootstrap model to compare that with the stochastic frontier, we didn't see any differences between the two methods, pretty much similar actually between the two. There were no significant differences between the two approaches. Of course, when you correct for sample bias, you do notice that now the facilities are all between 0 and 1, and none of them have a score of 1 in this case. When comparing the two methods, again, in terms of ownership, I had mentioned before, we didn't find any major significant sort of impact or effect of ownership on efficiency. And that's also still the same case with the DEA and SFA cross-sectional models, as shown in this particular slide here. So we didn't find any significant differences between the two types of hospitals when using DEA and SFA. So in summary, there is evidence of technical inefficiency in the sampled Kenyan hospitals, indicating that there's scope for improving efficiency. There's no clear consensus on the preferable method. They both have pros and cons. Therefore, if consistency estimates and comparable results are met, the methods can be used depending on the quality and accuracy of data and the description of the facilities or hospitals that you're including in your analysis. In a paper that was discussed by Jacobs et al., discusses 3 groups to sort hospitals or DMUs when comparing the two methods. The first one is where the relative efficiency is sensitive to the choice of the analysis technique. And you can do this using sensitivity analysis. The second one is, the second group is the DMUs that appear efficient no matter the model specified. And finally are the ones that appear inefficient irrespective of the model. We didn't quite see any significant patterns yet, and this could be driven again by the small sample size, but this is definitely an area to explore further in future research. As mentioned, we didn't find any significant changes over time in the Kenyan hospitals, and we also didn't find ownership as a significant factor driving efficiency or inefficiency in Kenyan hospitals. I did have some challenges, as mentioned, in terms of missing data. Some had completely missing data, which are excluded from the analysis. Some had within observations and variables, which we either sorted through imputation or excluded from any of the regression analysis. We had limited variables. There are other input and output variables, but also the other exogenous variables that can be explored. And generally, I had a relatively small sample size for this analysis. There's need for more data to understand and explore this, understand the efficiency levels in Kenyan hospitals, but also to apply some of the methods that have been set out in literature. We also be keen to look at other levels of hospitals, but also types of hospitals, including private for-profit type of hospital and other ownerships. In terms of the analysis, I mentioned that this piece of work was before devolution. So it'd be interesting to look at post-devolution analysis, looking specifically at now as our overall health system at the county government. We did receive a HSRI grant about two and a half years ago, and we are currently writing up that manuscript that looks at technical efficiency at the county level. Another potential area of research and a gap is looking at the linkage between efficiency and cost effectiveness analysis. So we do know that cost effectiveness analysis assumes that the cost of providing a particular level of service is minimized, but fails to account the differing levels of inefficiency and hence could have implications of the validity of the results of cost effectiveness analysis. Ideally, we should measure opportunity cost, but we do know in most of the CEA studies, we measure unit cost. And if the aim of economic evaluation is to move resource use towards economic efficiency, then opportunity costs are required. If costs vary because some of the hospitals or health centers are inefficient, then it is inappropriate to use costs that are representative of all DMUs or all hospitals. If costs represent opportunity costs, then ideally only those from the efficient DMUs are relevant. But there's a whole area in this that can still be explored in future research. It's a huge gap that's still there, and it'll be interesting to look at that more. Yeah, I'd like to, there are several projects that supported this work, but specifically the Ministry of Health, the government of Kenya, but also specifically the hospitals that supported with this work for it to be successful. Thank you.